So let's see the drugs for bronchial asthma. The class is corticosteroids. Here again we will see the mechanism of action. One more special feature in the corticosteroids is systemic steroid therapy. Then we will see the drugs of corticosteroids, that is inhaled steroids. Then we'll see the precautions of using corticosteroids. Then individual discussion on inhaled steroids. So let's start with the corticosteroids. Now here glucocorticoids are not bronchodilators. They benefit by reducing bronchial hyperreactivity, mucosal edema, and by suppressing the inflammatory response to antigen antibody reaction or other trigger stimuli. So this is about the glucocorticoid. They are not basically bronchodilators. But the realization that asthma is primarily an inflammatory disease, which, if not controlled, attenuates with time, and the availability of inhaled steroids that produce few adverse effects has led to early introduction and more extensive use of glucocorticoids in asthma. So basically, glucocorticoids or corticosteroids afford more complete and sustained symptomatic relief than bronchodilators or chromoglycate, what we have seen in the previous slides. These glucocorticoids or corticosteroids also improve airflow, also reduce asthma exacerbations, and may influence airway remodeling, also retarding disease progression. But however, long term systemic steroid therapy has its own adverse effects, which may be worse than asthma itself. So let's see the systemic steroid therapy in the corticosteroids. So basically, systemic steroid therapy is resorted to in asthma under the following two situations. In that first situation is a severe chronic asthma, and the second situation is status asthmaticus, which is also known as acute asthma exacerbations. So let's see about the first one, that is a severe chronic asthma. Now in this case, if it is not controlled by bronchodilators and inhaled steroids, or when they are frequent recurrences of increasing severity, so start with a prednisolone, that is 20 to 60 mg or equivalent daily dose. Also attempt dose reduction after 1 to 2 weeks of good control, and finally try shifting the patient on an inhaled steroid. Only few patients require long-term oral steroids. In that patients, dose should be kept at minimum dose. So this is about the severe chronic asthma. Now in the second, that is a status asthmaticus, which we are calling it as a acute asthma exacerbations also. In this asthma attack not responding to intensive bronchodilator therapy, let's start with a high dose of a rapidly acting intravenous glucocorticoid, which generally acts in 6 to 24 hours, and shift to oral therapy for 5 to 7 days, and then discontinue abruptly or taper rapidly. So this is all about the status asthmaticus. Now if we are going to see the COPD patients in this short course, that is 1 to 3 weeks of oral glucocorticoid may benefit in some patients of COPD. Now let's see about the inhaled steroids, that is a corticosteroid drugs. Now these are these inhaled steroids, glucocorticoids with a high topical and low systemic activity, and this is due to poor absorption and or marked first pass metabolism. Here the drugs are beclomethasone dipropionate, budesonide, and fluticasone have similar properties. Now cyclophosphamide is a new addition in this family of inhaled steroids because airway inflammation is present in early mild disease as well, and bronchial remodeling starts developing from the beginning. It has been suggested that inhaled steroids should be the step one for all asthma patients. However, currently inhaled steroids are not considered necessary for patients with a mild and episodic asthma. They are indicated when inhaled beta 2 agonists are required almost daily or the disease is not only episodic. So start with 100 to 200 microgram BD and titrate dose upward every 3 to 5 days, maximum 400 microgram, beyond which no further benefit generally occurs. So this is about the inhaled steroids. Now this inhaled steroids suppress bronchial inflammation. It increases peak expiratory flow rate. It reduces need for rescue beta 2 agonist inhalations and also prevents episodes of acute asthma. However, they have no role during an acute attack or in the status asthmaticus. Peak effect is seen after 4 to 7 days of instituting inhaled steroids, and benefit persists for a few weeks after discontinuation. Then they can be started in patients who in past have required oral steroids as well as in those with no such history. Patients who are to be switched over from oral steroid should receive inhaled steroid in addition for 1 to 2 weeks before the former is tapered. Otherwise, steroid withdrawal may manifest like precipitation of asthma, like muscular pain, like depression or hypotension in that patients. So this confirms the lack of systemic activity of inhaled steroids, and the doses, at which doses, it's less than 600 microgram per day. So long term experience has shown that efficacy of inhaled steroid is maintained, and reinstitution of oral steroid is seldom needed. Basically, short courses of oral steroids may be added during periods of exacerbation. Some patients who remain well controlled for long periods can even stop inhaled steroids without worsening of the asthma. Now, if we are talking about the COPD patients, so high dose inhaled steroids are beneficial only in advanced COPD with frequent exacerbations. Should not be used early or mild cases. There is no proof that they show slow disease progression. Now, hoarseness of voice, then dysphonia, then sore throat, asymptomatic or symptomatic oropharyngeal candidiasis are the most common side effects with this. Now, this can be minimized by the use of a spacer, gargling after every dose, like to wash off the drug deposited on oral and pharyngeal mucosa. So, for this, gargling is required and prevented as well as treated by topical nystatin or clotrimazole. Actually, there is no evidence of mucosal damage or increased incidence of chest infections even on prolonged use. In these, systemic effects of long-term inhaled glucocorticoids are clinically relevant only at a doses more than 600 microgram per day. That's why the dose required is less than 600 microgram per day. The significant ones are like mood changes, then osteoporosis, growth retardation in children, then bruising, hyperglycemia, and pituitary adrenal suppressions. Several reports of adrenal crisis have appeared even, especially in children during stress of an infection, etc. etc. So, these inhaled steroids basically are safe during pregnancy. Now let's learn about the drugs. Here I have summarized in the table, that is a budesonide, then fluticasone propionate, flunisolide, and 6-lesonide. So here features, uses, and dosage we have given. Here with the budesonide, it is a non-halogenated glucocorticoid with high topical systemic activity ratio, and it is claimed to be better than a beclomethasone. So small fraction that is absorbed is rapidly metabolized. The dose for this 200 to 400 microgram BD or QID by inhalation in asthma. Then 200 to 400 microgram per day by intranasal spray for allergic rhinitis. The brand names are Pelmicort, then Budecort, then Foracort are available in the market. This Foracort has nothing but the formoterol, that is 6 microgram, and budesonide 100 microgram per 200 microgram rotacaps. So this is about this budesonide. Then fluticasone propionate, this is a newer inhaled glucocorticoid which has a high potency, also longer duration, and negligible oral bioavailability. The dose swallowed after inhalation has a little propensity to produce systemic effects, and at high doses, systemic effects may be due to absorption from the lungs. So the inhalation dose is 100 to 250 microgram BD. Maximum we can give 1000 microgram per day. Then flunisolide, this is the topical steroid. It is available for prophylaxis and treatment of seasonal and perennial rhinitis. Here 25 microgram of Synatris brand name per actuation nasal spray, and one spray in each nostril 2 to 3 times a daily. Now cislesonide, this is the inhalational steroid, utilizes novel approach to improve topical systemic activity ratio. It is a prodrug that is cleaved by esterases in the bronchial epithelium to release the active moiety. Prodrug is nothing but which is inactive outside and making active inside. Through it is absorbed through the lungs, and then oral bioavailability is less than 1%. In the circulation, this cislesonide extensively bound to plasma proteins and further minimizing the exposure of tissue cells to the free and active drug. So in this uses in the asthma, as we know, and the dose is 80 to 160 microgram by inhalation OD, preferably in the evening. This dose is given. The brand name like Ciclase, it's a 80 microgram and 160 microgram per meter dose inhaler with HFA propellant. Now let's start with the next class, that is a anti-Ig antibody. Here the omalizumab drug we will study, then we will see the use and mechanism of action for the same. Now let's see the use. It is used only in severe extrinsic asthma, and it is very expensive, so use of it is restricted for the resistant asthma patients, then patients giving positive skin test, and patients with a raised Ig level who require frequent hospitalization. Okay, now the drug omalizumab in the anti-Ig antibody, we'll see the mechanism of action. This omalizumab is a humanized monoclonal antibody against IgE. That's why this class under the anti-Ig antibody. This omalizumab administered intravenously or subcutaneously. It also neutralizes free IgE in circulation without activating the mast cells and other inflammatory cells. On antigen challenge, little IgE is available, which is bound to the mast cell surface receptors. These are FR1 cells, which trigger mediator release and causes bronchoconstriction. In severe extrinsic asthma, this omalizumab has been found to reduce exacerbations and steroid requirement. It is very expensive and use is reserved for the resistant asthma patients with a positive skin test, what we have seen in the previous slide, or also raised IgE levels who required frequent hospitalization. It is not itself immunogenic, only injection site local reactions have been noted so far for this. It is being tried in other allergic diseases as well. Now, till this, we have seen the inhaled asthma medications, the 4 classes of anti-asthma drugs, for example, beta-2 agonist, then anticholinergics, chromoglycate, and glucocorticoids are available for inhalational use. They are aimed at delivering the drug to the site of action so that lower dose is needed and systemic side effects are minimized. Most asthma patients are now maintained or inhaled medications only. Aerosols are of 2 types for used in the asthma disease. It's a use of drug in the solution, that is a metered dose inhaler or a nebulizer. This is the first class of aerosols. And the second type, use drug as a dry powder, that is a spinhaler or rotahaler. So basically under these 2 types only aerosols are divided for the asthmatic patient. Use drug in solution, that is a metered dose inhaler or nebulizer. And the second one is use drug as a dry powder, that is a spinhaler or rotahaler. Now metered dose inhalers use chlorofluorocarbon or a hydrofluoroalkane, that is a HFA propellant, and delivered a specific dose of the drug in spray form per actuation, per click we can say. Now device actuation has to be properly coordinated with a deep inspiration, which many patients are unable to learn. So that's why the spacer, there is a chamber interposed between the inhaler and the patient's mouth, can be used to improve drug delivery. Now in case of nebulizers, these nebulizers produce a mist of the drug's solution, which is generated by pressurized air or oxygen, which can be inhaled through a mouthpiece, face mask, or in a tent we can inhale it. Now in metered dose inhalers, these metered dose inhalers are convenient handheld devices which can be carried along, while nebulizers are used at a patient's bedside only. We cannot carry them every time. The nebulizers are preferred for severe episodes of asthma as well as for children and in elderly patients. More than one drug can be nebulized simultaneously in the nebulizer. Now in case of dry powder inhalers, we are talking like these are also portable devices in which the capsule, that is rotacap, containing drug is punctured or cut across the powder, and it's aerosolized by the inspiratory airflow of the patient. It requires high velocity inspiration, which children or elderly and very sick may not be capable of. So the dry powder is also more likely to irritate the air passage and producing cough and bronchoconstriction. These are the side effects of dry powder inhalers. Now if we are talking about the efficacy, so efficacy of aerosolized drug depends on the particle size. Particle size 1 to 5 micrometer diameter particles deposit on the bronchioles and effectively deliver the drug. Now larger particles settle on the oropharynx, while the very fine particles do not settle anywhere. and are exhaled out simply. On an average, only 4 to 10% of the inhaled drug reaches the site of action. So, this is a considerable fraction which is swallowed. Therefore, to minimize the systemic action, the drug should have low oral bioavailability. In this, spacer devices improve inhaled to swallowed drug ratio. Here, slow and deep in breathing after device actuation and holding the breath after inhalation also enhances efficacy of the inhaler. So these are the classes, these are the drugs what we have studied in the bronchial asthma part of the respiratory drugs, and these are the devices through which the drugs we can intake for the better efficacy. And what are the chances to improve it? What we have seen here. Now let's see the choice of treatment. We will discuss a stepwise guideline to treatment of the asthma as per the needs of the patient has been recommended. So one by one we will see. These are the some points I have highlighted here. That is a mild episodic asthma. Now mild episodic asthma, here symptoms less than once daily or normally in between attacks. Inhaled short acting beta 2 agonist at onset of each episode is required. No regular prophylactic therapy. This is the step 1. Then in the seasonal asthma, this seasonal asthma start regular inhaled chromoglycolate, low dose inhaled steroid up to 200 to 400 microgram per day. This dose already we have seen in the corticosteroids class. Then 3 to 4 weeks before seasonal attacks, and continue till 3 to 4 weeks after the season is over. This seasonal asthma treat individual episodes with a inhaled short acting beta 2 agonist. Then in the mild chronic asthma with occasional exacerbations, is symptoms once daily or so. Then regular inhaled low dose steroid. This is the second step. The first step we have seen in the mild episodic asthma. Here in mild chronic asthma, alternatively inhaled chromoglycolate is given. Then episode treatment with inhaled short acting beta 2 agonist. Then the fourth one is moderate asthma with frequent exacerbations. Here attacks affect activity occur more than one per day or mild baseline symptoms we can see in the moderate asthma. Then the treatment is increasing the dose of inhaled steroid, that is up to 800 microgram per day. This dose, remember, corticosteroid dose we can increased up to 1000 microgram per day only. Beyond that we cannot increase. Then with this corticosteroids plus inhaled long acting beta 2 agonist, here the step 3 comes. And leukotriene antagonist may be tried in patients not accepting inhaled steroids, and in those not swallowed, not well controlled. So leukotriene antagonist may be used instead of beta 2 agonist and steroid, especially steroids. Also we can use theophylline, may be used as an alternative additional drug, and the episode treatment with inhaled short acting beta 2 agonist. Then in the severe asthma, it's a continuous symptoms, activity limitations, then frequent exacerbations or hospitalization is required. Here regular high dose inhaled steroid, that is 800 to 2000 microgram per day even, through a large volume spacer device plus inhaled long acting beta 2 agonist. Here the drug we can use salmeterol twice a daily. Additional treatment with one more of the following, that is a step 4, is a leukotriene antagonist or sustained released oral theophylline or oral beta 2 agonist. Then inhaled dipetropium bromide we can give. Then rescue treatment with short acting inhaled beta 2 agonist. In patients not adequately controlled or those needing frequent emergency care, institute oral steroid therapy. Attempt withdrawing oral steroid periodically. Otherwise, the patients will show severe side effects of withdrawing. Then, in the last one, status asthmaticus, which is also known as refractory asthma. Any patients of asthma has the potential to develop acute severe asthma, which may be life threatening. Upper respiratory tract infection is the most common precipitant. Here, hydrocortisone hemisuccinate, that is 100 mg, or equivalent dose of another glucocorticoid through intravenous, followed by 100 to 200 milligram 4 to 8 hourly infusion, and may take up to 6 hours to act. Then second, here in the status asthmaticus or refractory asthma, nebulized salbutamol, that is 2.5 to 5 mg, plus ipratropium bromide, that is 0.5 mg intermittent inhalations, which are driven by O2. Then high flow humidified oxygen inhalations can be used. Also salbutamol or terbutaline 0.4 mg intramuscularly or subcutaneously may be added, since inhaled drug may not reach smaller bronchi due to severe narrowing or plugging. Also, intubation and mechanical ventilation if needed in these patients with a status asthmaticus. Treat chest infection with intensive antibiotic therapy. Also, correct dehydration and acidosis with a saline plus sodium bicarbonate or lactate infusion. So these are the some combinations of the treatment we can use, that is a choice of treatment for treating the asthma. Here I found one interesting table from GINA 2020. You can see, have a look in detail. That is a patients with features of asthma and COPD. Just go through it. This is just a extra information. It is not a part of the syllabus, but definitely it will help out to understand bronchial asthma, then cough, what we are going to see in the next slide, and also choice of the treatment and history, and what are the functions and history of the asthma. You can have a look in this table. This is as usual, I have taken from the GINA 2020. You can visit this site for this global initiative for asthma, and every year they produce the reports. So those who are interested, they can search for the GINA, and that is a global strategy for asthma management and prevention. And this is particularly for educational purpose only.